Hello, my name is Ajarvis, and I'm a fourth year professional pharmacy student at Florida A&M University. And today we'll be talking about a trial titled The Initiation of Antiretroviral Therapy in Early Asymptomatic HIV Infection. Generally, in practice, deferring the initiation of antiretroviral therapy in asymptomatic patients with a CD4 count above a certain threshold level was acceptable. However, this threshold has changed over time and recommendations remain inconsistent across various guidelines. Recent studies that have assessed the benefits and risk of treating patients, with HIV sooner rather than later provided evidence of initiating therapy when the CD4 count is above 350 cells per millimeters cubed. However, the results of these trials, have been inconsistent and there has been a large amount of bias within them. So this trial wanted to focus on the risk and benefits of immediate initiation of antiretroviral therapy in asymptomatic HIV positive patients with a higher CD4 with a CD4 count of more than 500 cells per millimeters cubed. And this trial was funded by the National Institute of Allergy and Infectious Disease, and antiretroviral therapy medications that were utilized were donated by companies such as AbbVie, Bristol Myers Squibb, GlaxoSmithKline, Janssen, and Merck. So the START trial, also known as the Strategic Timing of Antiretroviral Therapy, was designed and conducted by the INSIGHT Study Group, also known as the International Network of Strategic Initiatives in Global HIV Trials. This is a multi-center, multi-continental randomized controlled trial conducted in 6 regions, 35 countries, and 215 sites. The inclusion criteria was patients had to be greater than or equal to 18 years old, had to have never received antiretroviral treatment, had no history of AIDS, and had to have two CD4 counts above 500. And these CD4 counts must have been 2 weeks apart and within 60 days of enrollment. The exclusion criteria consisted of pregnant women or breastfeeding at screening, diagnosis of AIDS, cardiovascular event within 6 months, dialysis within 6 months, history of cancer, history of decompensated liver disease, and current imprisonment. The design of this trial had two treatment arms. The first was the immediate initiation group, and the second was the deferred initiation group. And the immediate initiation, all patients had a CD4 count of greater than 500, and in the deferred initiation group, therapy wasn't started until your CD4 count declined to 350 or development of AIDS or AIDS-defining condition. The primary endpoint of this trial was the composite outcome of any serious AIDS-related event and any serious non-AIDS-related event. Various AIDS-related events consisted of Kaposi sarcoma, pneumocystis jirovecii infection, toxoplasmosis infection, among many other bacterial infections. And non-AIDS-related events consisted of heart attack, stroke, death from a cardiovascular event, end-stage renal disease, non-AIDS defining cancer, and death from cancer. Secondary outcomes included, serious AIDS-related events as one entity, serious non-AIDS-related event as one entity, death from any cause, grade 4 events, unscheduled hospitalizations of reasons other than AIDS. And the endpoint review committee that reviewed the various events that occurred was actually blinded, which was good for the trial, and they had pre-established criteria for classifying the events. During the trial, they used interim monitoring using O'Brien-Fleming boundaries and Landametz, and they used those to monitor the safety and benefits of the trial while follow-up was occurring, and utilize that to bring the trial to an end once the primary endpoint was answered. And these methods were utilized to prevent an unnecessary increase in type 1 error as they were doing these interim monitorings. The intention to treat principle was utilized in the statistical analysis, and intention to treat is good for real world scenarios because everybody that is randomized is included within the results. So, it takes into account, that, in real world, patients, aren't sure, perfect, cookie cutter patients. It takes into account, missed outcomes and non-compliance. Time to event methods to compare the events of the primary endpoint were analyzed through Kaplan-Meier curves and Cox proportional hazard models. The Kaplan-Meier curves, allows for estimation of survival over time, and takes into account, even when patients drop out or are studied for different lengths of time as they are in this trial. The cost proportional hazard model actually determines the impact of these outcomes, on the time to occurrence of an event. And I felt both of these methods were appropriate because the study was trying to determine the occurrence of events on the early initiation of antiretroviral therapy. So more about the results. Uh, Mean follow-up time was 3 years and 4,685 patients were enrolled. 2,326 in the immediate initiation group and 2,359 in the deferred initiation group. Baseline characteristics were remarkably even between the two groups, ranging from, age, race, gender, even mode of infection. And I felt like they did a very good job of including the men who have sex with men population in this trial. The medications that were primarily used were tenofovir, emtricitabine, and efavirenz. And as a result, as it pertains to HIV viral RNA counts, the deferred initiation group had higher viral RNA counts at the start of the trial, and the results showed that at full viral suppression by 12 months were similar in both groups at a 98% for the immediate initiation group and 97% for the deferred initiation group who started antiretroviral therapy. And as it pertains to the CD4 count, the immediate initiation group increased markedly after the first year since they started antiretroviral therapy immediately. And deferred initiation group decreased during the first year and then began to increase slightly as more patients started to receive treatment. So in the immediate initiation group, 42 patients were reported to have the primary endpoint, which was the composite of AIDS-related and non-AIDS-related events, which was actually 1.8% of the total subgroup population. And in the deferred initiation group, 96 patients reported the primary outcome, which was 4.1% of the subgroup population. And the analysis between the two expressed a p-value of less than 0.001, which was found to be statistically significant. Between the secondary outcomes, the three most common events that occurred was cardiovascular disease, non-AIDS defining cancer, and tuberculosis. Tuberculosis mostly occurred in Africa, and cardiovascular disease and cancer mostly occurred in your more high-income countries. So overall, the secondary outcomes were less common in the immediate initiation group, and outcomes for serious AIDS-related non-AIDS-related events, tuberculosis, and Kaposi's sarcoma were found to be statistically significant among the secondary outcomes. Other clinical events that happened, which the author wanted to note, was the rate of bacterial infections between the groups. They were found to be significantly reduced in the immediate initiation group, and it was also found to be statistically significant. So overall, the author concluded that the antiretroviral therapy should be recommended for patients in whom HIV has been diagnosed regardless of CD4 count. The benefit of immediate initiation seen through the trial was quantified and safety was assessed over a number of various outcomes. The author noted that most of the AIDS-related events occurred when patients had a high CD4 count of more than 500 cells per millimeters cubed, and the limitations that they stated were that there was a percentage of primary events that were attributable to the serious non-AIDS defining events that was lower than anticipated before the trial occurred, which shows they were not able to effectively study the risk of immediate therapy on serious non-AIDS defining events. Also, another limitation was that it was a short period of study. Like I said before, the mean time was 3 years, and it just gives a snapshot for patients who will generally be on these medications for the rest of their lives. So while analyzing this study, my personal opinion, I felt the trial was effective in shedding light on immediate initiation of therapy at HIV diagnosis regardless of CD4 count. The relative reduction in the primary endpoint was significant in the immediate initiation group, and these findings can be utilized in practice to slow the progression of AIDS, achieve viral suppression, and improve the quality of life in these individuals. Personally, I would definitely utilize this data for my own patients to achieve viral suppression and prevent the transmission of the disease. So, as my search to find other primary literature, I found a trial that was published in 2015 in the New England Journal of Medicine, and it was titled A Trial of Early Antiretrovirals and Isoniazid Preventative Therapy in Africa. Their aims were to assess the benefits of early antiretroviral therapy, 6-month isoniazid preventative therapy, or both among HIV infected adults with high CD4 cell counts. The primary endpoint was a composite of diseases, including AIDS, non-AIDS defining cancer, non-AIDS defining invasive bacterial disease, or death from any cause at 30 months. A total of 2,056 patients were randomized into 4 treatment arms, the first being deferred antiretroviral treatment, the second being deferred antiretroviral treatment plus the isoniazid, the third being early antiretroviral treatment, and the fourth being early antiretroviral treatment plus the isoniazid. Results showed the risk of death or severe AIDS-related illness was lower with early antiretroviral therapy than with deferred antiretroviral therapy, which is similar to the START trial in that the immediate initiation of therapy is effective in slowing illness and the risk of death. So the authors in this study concluded that the immediate antiretroviral therapy led it to lower rates of severe illness overall and among patients with CD4 counts of at least 500 cells per cubic millimeters. So as a conclusion to both of these trials, they both showed that early antiretroviral therapy is useful in patients to prevent illnesses and slow the transmission of the HIV epidemic. And that concludes my journal club. Thank you for listening.